This is yet another episode of, Umwe Sit Downs, where we talk with experts, leading minds about important issues that they're working on and care about. Today I'm joined by Dr. Afulani and Dr. Awoonor, who both did amazing work, learning and studying Ghanaian healthcare workers at the beginning of the pandemic to understand the stress levels and factors contributing to those levels early on in the pandemic. Dr. Afulani, welcome, and could you please just say a message or two about you being happy to be here, and perhaps briefly what it is that you work on and sort of like during the regular week.
Yeah, thanks, Brian. I'm happy to be here. My name is Patience Afulani. I'm an assistant professor at the University of California in San Francisco, but I am Ghanaian, born and raised in Ghana. I do research on maternal and child health, but also generally on quality of care and some of the factors that impacts healthcare workers' ability to provide high quality care. And so have started looking at issues around stress and burnout and how that influences quality care in the context of this pandemic also.
Right, and thank you so much for being here with us today. And Dr. Awoonor?
Yeah, thank you so much also to join you and Patience to have a chat on some of the work that we have done regarding COVID. My name is Koku Awoonor. I'm a public health specialist and work in the area of health policy, health systems, currently doing some consultancy work with other groups in the country.
Wonderful. Thank you so much, Doctor. And so, yeah, we to get right into the interesting work that the two of you have done. I'd like to start out with a question for Dr. Fulani here. Which is about essentially, some of the interesting conclusions you've made. So, yes, early on in the pandemic, you conducted a survey measuring how stressed and burnout Ghanaian healthcare workers were. So what were the key conclusions of that study, and what did you learn contributed to the stress or lack thereof in the healthcare workforce of Ghana?
Yeah, so our main conclusion in this study was that many healthcare workers in Ghana were experiencing high levels of stress and burnout, and perceived lack of preparedness was a key factor contributing to this. So we found that about 7 out of 10 healthcare workers were experiencing moderate to severe levels of stress, as well as burnout. And most importantly, about 20% were experiencing high levels of burnout, which is also considered clinical burnout, and so manifesting as physical exhaustion, emotional exhaustion, and cognitive weariness. In addition, less than a third of providers felt prepared, and we found that those who had lower levels of preparedness had higher levels of stress and burnout. Not feeling prepared influenced whether or not providers felt that they were likely to get infected, and this also in turn led to high stress and burnout. Importantly, about half of providers were fearful that they would get COVID-19, but only 20% were confident that they will be adequately cared for in their facility if they got infected. On the other hand, providers who felt that their management was supporting them and appreciated their efforts had lower levels of stress and burnout. Similarly, those who felt their families were supportive had lower levels of stress and burnout. And so in general, low perceived preparedness, fear of infection, low perceived appreciation from management, and low perceived support from family were the factors that contributed to high stress and burnout.
Right. Thank you so much, Dr. Fulani. I think one of the key things reading about your study and also hearing your profound answer here is that lack of preparedness stood out strongly in terms of feeling ready to navigate the pandemic, and also feeling equipped, right, to sort of have the PPE and so forth sufficient to respond to the pandemic. So Dr. Awoonor, is on what grounds did, on what specific grounds did workers though kind of feel unprepared to deal with the pandemic? And could you tell us a bit more about whether those concerns were justified to have? I think it's especially interesting to answer that now that we can sort of look at it retrospectively, after the fact.
Thank you very much for saying even that we can now go back and look at it retrospectively. What I would like to say, and as to build on the point that Patience made, was that we actually measured our perceived preparedness using what we call a 15-item scale. And that scale captured both personal, facility, psychological preparedness for prevention, as well as diagnosis, management, and education regarding COVID-19. So the lack of preparedness was actually related to all these major domains within the study that we did. But interestingly to note is that in addition to lack of preparedness, this was influenced by training on COVID-19, by availability or non-availability of PPEs, even protocols to be able to navigate, treatment and all that. And importantly for Ghana, and I'm sure for other countries, also the lack of, use of the isolation wards availability. Okay, whether there's isolation ward available for people to be able to be admitted or to be put in isolation. But one of the other things that came out clearly was the lack of communication from management about COVID. I mean, this is a situation where we had COVID came up, things were going in the normal health system. Hey, but how was even management communicating with the health staff in terms of COVID? For example, at the time of our survey, only 7% reported their facilities had enough PPEs. And this cuts across almost, the continent in terms of lack of PPEs. And only half of them had reported that they had any training on COVID. So these are quite interesting results that we got there. Additionally, also only 2/3 reported that they had an isolation ward for COVID-19 cases in their facilities. So here's a case where you have COVID, people are coming for treatment, but then even where to put them because of the nature of the disease was a challenge. Only have reported they have that. And so that was a major problem. But in addition to that also, about half also reported that they had protocol for managing COVID-19. So you have issues with isolation ward, then you also have issues with protocols for management. For us in Ghana, as we did this study, we also thought that this was not very surprising, given what we already knew from the media, from reports, from healthcare workers who were reporting across the country. And we also know that, at the beginning of COVID, even in high-income countries or settings, lack of PPE was a major problem. That has been widely reported. Even guidelines and protocols for training and management were just evolving. So we think that this study was certainly, justified for the result that we got from the training.
Right. Thank you so much, Dr. Awoonor. I think there was a very focused and detailed sort of breakdown of what key areas where people were causing people to feel this unpreparedness, right? And I think to draw two key things, it seems like it's training and the lack of PPE, but certainly a third element that stood out is what you said, communication from management. And so, with those sort of three things that are picked up, and perhaps, there's a bit more to that list. Dr. Afulani, could you please comment on sort of like what on the solutions then? Is it providing more PPEs and the training that was cited by your team as a solution at the time, and retrospectively, how has that played out in terms of what seemed to have been, the right steps to take in order to navigate the pandemic well?
Yeah, thanks, Brian. So from our findings, the direct recommendations are certainly related to the factors that influence preparedness. So for example, Dr. Awoonor mentioned providers who had undergone training on how to diagnose, isolate, and manage patients felt more prepared. And so they felt less stressed, which means that interventions to reduce stress and burnout needs to increase providers' capacity and their confidence to be able to identify and manage COVID-19 through training. Also, we know that healthcare providers who had the necessary resources, so particularly having enough PPEs available, having protocols, having isolation wards, and also importantly, as Dr. Awoonor mentioned, those who perceived that communication from management was good, felt more prepared. And so these are all things that we need to be addressing to reduce stress and burnout levels, making PPEs readily available for providers, having clear protocols, equipping facilities with isolation wards, and improving communication could all decrease stress and burnout levels. And we also need interventions that will improve the morale and sense of appreciation from management and other health system workers. So providers need to know that the efforts they are putting in are being appreciated. Family members need to support their families who are healthcare providers. And society in general needs to be showing appreciation for healthcare workers in this time. We've heard instances of healthcare workers being stigmatized because of their high risk of exposure to the virus. And all of this contributes to stress and burnout. But I should say that stress and burnout among healthcare workers predates the pandemic. We recognize that burnout among healthcare workers was a pandemic itself before even the COVID-19 pandemic. And so we need to be thinking about the broader drivers of burnout, such as the overwhelming workload that healthcare workers in Africa have to deal with, the lack of critical resources to carry out their roles need to be addressed. We need basically all the things we need to do to strengthen the workforce, to strengthen the overall health system are things that will decrease stress and burnout among healthcare workers. But also important to note that, these are all sort of long-term changes. And while we are dealing with that, we need to begin to help providers to develop positive coping mechanisms for the stress. There's an inherent stress with working with sick people that cannot be eliminated. And so providers need the training to develop positive coping mechanisms and to build resilience to be able to respond to these situations that are unavoidable in the life of a healthcare worker.
Right. Wow. Thank you so much for sharing that, Dr. Afulani. And if I may ask a follow-up question on that, I think one key thing that stood out, especially hearing about how you're describing the situation in Ghana versus what is happening in where I'm calling you from, Namibia, is that I think a crucial element to sort of responding effectively was a collaboration between private hospitals, the government and government hospitals, as well as the hospitality facilities that were otherwise idle nonetheless because of no tourism. Hospitality, different hotels and whatnot were turned into essentially quarantine camps and places where people who are sort of recovering could be treated and moved from a hospital to those to such facilities. So I'm very curious to hear about how perhaps maybe not in terms of the logistics of handling patients and whatnot, but from the solutions that you cited from your study, has sort of Ghana gone on to implement one of those that you can see has contributed well to how the country has ultimately managed the pandemic over the last year or so. So yeah, any sort of solutions that were implemented that you'd like to share and highlight that has really gone on to kind of contribute in some way, shape, or form to how Ghana has fared with the pandemic.
Maybe let me contribute to that before patients come in. I think that the findings were very relevant. Yes, this study was done in Ghana, but if you look at the global picture of COVID, one would say, hey, perhaps this is just one corner one country in Ghana, but I think it's replica. I mean, the same issues that occurred in many of the low-income countries. But for specifically in Ghana, and I think for other countries, the findings were in tandem with the initial responses and shock within the health system, okay? So there was lack of PPEs, there was no guideline on COVID, there was no protocols to follow, communication around COVID was poor, management was not being, communicative with the staff. Over time, and as we learn and move on, and based on some of the issues that patients just raised, things improved. Ghana, for instance, for lack of PPEs, for instance, we were locally manufacturing face masks, nose masks, and all that. Okay, it's a good response. There was a technical team that quickly went into action to develop guidelines and protocols for communicating and even for public education. So if you take all those specifics in terms of those challenges that we found in our studies, over time, there had training, for instance, for health staff was intensified, and therefore people were able now to diagnose. In terms of the point that you rightly said, the initial shock is that, look, there were not enough places for isolation. But what we do, we have hotels in Ghana, we have in districts and communities, what I call appropriate technology in terms of shifting some of those structures into isolation wards, even though they might not necessarily be the best, but at least those efforts were made to be able to ensure that, COVID patients were isolated or quarantined and appropriate action is taken for their next step. So yes, quite a number of actions that have been taken locally in Ghana. I mean, one of the things that amazed me was of course, most of our medical supplies come from China. China was in the lockdown. We could not get, PPEs, sanitizers. We could not get nose masks. Already then we have local manufacturers who are already manufacturing, even using local cloth materials to be able to sew nose masks. Then we have local industries that went into manufacturing of, sanitizers, at a point that we were not even going to even import sanitizer into the country. So the response was swift, it was local, and we think that was quite innovative, and I needed to highlight that. I don't know if Patience wants to add something to that.
No, I think you've covered all of it.
Right, and Dr. Awoonor, I think thank you so much for your input. And I think you've already touched on this, but I'd like to proceed to kind of get your take on the extent to which you think the situation in Ghana resembles that of most African nations. And I know, academically, it's not favored and too wise to kind of draw those broad assumptions. But I'd just like to kind of hear your comment on how, to what extent you think your findings resemble what the situation in other countries. I know you sort of already touched on it, but whatever you'd like to share on that, sir.
Yeah, very, very, very important question, because that question often gets asked, especially when you are doing research, and the question is, how replicable is this to other settings? The question of this can work here, can it also work in this setting, etc. But I think on a large, our findings are likely replicable in other low resource settings. I mean, yeah, the continent, and even for me, for the kinds of findings that we had, and of course, the kind of solutions and recommendations that we have made, you might even go and say, look, not only low resource settings, but even globally, these findings are replicable, because importantly, it highlights the need for interventions to increase provider preparedness. And our healthcare workers are very important. And I think that if they are prepared to be able to meet all these, circumstances, they'll be able to deliver, services better and effectively. So that is my take on that. That yes, it's replicable not only in low resource setting, but also I can confidently say that even globally, because this cuts across. Lack of PPE was all over all over the place, not only in Africa, not only in Ghana, but we had all challenges, documented in various publications about lack of PPEs in even, well-resourced countries. So yes, we can easily replicate this.
Yeah.
Interesting. Yeah, sorry, Dr. Afulani. Yeah, please feel free to comment.
No, I just wanted to add that. So we actually launched the second phase of the survey that also included Kenya. And so far, the findings from Kenya are not that different from what we have for Ghana. And so we have some data to support that the situation is very similar in Kenya as we found in Ghana, which also increases the chances that we'll find similar things in other settings.
Right. Thank you so much for sharing that with us. So I think this conversation has been very interesting, and this is sort of leading to my last question for Dr. Fulani, whereby I think we've learned so many things here, right? Training in terms of just general training on being a healthcare worker or a nurse, in the middle of the pandemic. What does that role look like? And the sort of availability of PPE, right? And again, those things were sort of proposed as solutions. And I think in so many cases in Ghana and across the continent, you've seen countries do those things, and other sectors, the private sector, come in as Dr. Awoonor was describing, where entrepreneurs and whatnot are producing sanitizers and face masks. But I think I'm very curious to then learn about what about globally, any plausible solutions that have been seen globally that sort of address and manage stress and burnout levels among healthcare workers that you would have liked maybe in the past, or still would like to see implemented in the African context. Because I'm sure maybe perhaps there's some sort of specific example out there that has pioneered something that you'd really like to see. So this is just a comment to hear from you, Dr. Afulani, if there's any solution of that kind, or multiple solutions that you can share with us here.
Yeah, sure. So, I mean, globally, there is a bit of work going on interventions to address provider stress. Mindfulness-based stress reduction strategies have been implemented in other settings as a way of helping healthcare providers deal with stress and burnout. I should say that these are important, as I mentioned, because there are some of those stresses that we can't take away, that by virtue of being a healthcare worker, you're going to be exposed to some level of stress. And so these individual level interventions that help providers to cope are important. But the research also shows that while these individually targeted interventions are helpful, more lasting change occurs when the source of the stress and burnout is removed. So instead of putting the onus on individuals to deal with their own stress, we want to begin to look at organizational change. How can we change the health facilities? How can we change the health systems such that providers are thriving within these health systems? So like I'd mentioned earlier, beyond this pandemic, even in both low and high resource settings, the biggest source of stress and burnout for healthcare workers is usually the workload, the long work hours, as well as not just having the things you need to do the work you have been trained to do. And so for lasting change to occur, we need organizational change. We need greater commitments through increasing the number, the scale of healthcare workers. We need improvements to infrastructure, equipment, medicine supplies. Basically, all the things that need to be done to strengthen the health system is what we need to ensure that providers are thriving within that healthcare system. We might think beyond, just in the context of this pandemic, but we need to be thinking forward in terms of what we need to make sure that we're ready for the next one. And I'm sure Dr. Awoonor has a couple of things to add also.
Yeah, thank you very much, Patience. I was smiling because you were reading my mind, talking about how do we have a resilient health system. And the point is that we must keep on reminding ourselves of the health system building blocks. I mean, the point that you made now means that, yes, we need to actually be on point in terms of addressing many of these challenges as it relates to the health system building blocks. Service delivery, human resource, logistics, health formation, data for decision making, etc. But to add to that, I think that in the context of this pandemic, I think also incentives and system changes for health workers, and that in my view will increase the morale of health workers. And of course, their capacity to be able to deal with this pandemic. Importantly, we need to have governments and other stakeholders institute what I call the necessary things that needs to be done, training, incentives, PPEs, protection, staff, all these things that will go a long way to improve the psychological well-being of the health worker. I mean, you already know that we have challenges in Africa, particularly with human resource, the health workforce shortage. And I believe strongly that, with what we have seen in the past, that a high number of these healthcare workers were infected and therefore were not available to provide services. Inadequate PPEs, the lack of protocols, leading to a lack of preparedness, etc. And of course, the growing demand on such health workers when they are infected and could not provide services. I think that, we need interventions to be able to critically address this. And it's important that stakeholders, government, everybody comes on board so that we can find solutions. Our study is very important. We think that we have made some contribution to the discussion. And it's important that we go beyond the recommendations and see how we can rally, support, get government, get stakeholders, get partners, who are in the health sector, NGOs, CSO, to be able to come together and support this kind of work that will address these systemic changes. So I share the same view that the patient just said. Sitting on the ball, making sure that, we look at all the levels of the healthcare system, at the community level, at the district level. Sometimes you have the tendency to focus at the national level, okay? But a lot goes on down there in the community level, and that also needs, so that we have a chain, a continuum, of care that is well provided by healthcare workers who have a high morale to be able to, and incentives to be able to provide those services.
Right. Well, very powerful closure from Dr. Awoonor here. And I think, the energy and solutions that you provided just kind of show, how much focus and I guess, potential there is to actually address these issues, where they're not just daunting issues, but, there are sort of many paths to be taken here. So thank you so much for your time, Dr. Awoonor and Dr. Afulani. It's been a pleasure unpacking your work, your wonderful work, and certainly was excited to learn about this study in the context of Ghana, because I think in many countries, unfortunately, it's just an opinion or a fear, and so it's really great to see that your team has gone on to really conduct this study to put some facts to the matter. And as you know, we're dealing with so many pandemics. One of them was an information one, and so great job on tackling that pandemic too. Any last words from our team here?
No, I'll just say thanks for having us. One of the issues we have with research is that it sets in publications where people who need to hear it don't get to read them. And so it's good to have the opportunity to disseminate our findings outside of the traditional publication route.
I've always talked about the disconnect between research and policy and implementation. So you made a very important point, Patience, that we need to start bridging that gap between research, policy, and implementation. And I think that this is one of the critical examples that can be used to address those challenges. And moving forward, getting everybody at the same time on the table to start talking about some of these issues that are affecting our healthcare system. And I think the pandemic is one example that we need to learn from.
Very well said, very well said. Well, with that, I'll stop recording, and until next time.